regarding this presentation can be found on your textbook pages 516 and 517. Before we begin, I have a few notes regarding sexual assault. Sexual assault remains one of the most underreported issues and one of the issues that medical treatment is neglected on. There are many reasons, and it varies individual of why treatment isn't sought. And sexual assault requires careful follow-up and monitoring, as PTSD tends to appear in 33 to 45% of the cases of female survivors. Most laws regarding sexual assault and sexual abuse have been rewritten in the last 2 to 3 decades to make the laws more gender neutral. And the definition of some of the terminology you might see coming up as far as the legal status goes is sexual assault is defined broadly as sexual acts that include fondling or non-penetrating acts as well as rape. Sexual abuse is described as the involvement of a child in sexual activities that the child cannot comprehend and in which the child is developmentally unprepared and cannot provide consent and or it violates laws or social taboos of family roles. This would include incest, which is sexual contact between family members. Sexual exploitation refers to acts without sexual contact but are which nonetheless viewed as potentially harmful to the child, such as having children pose for sexually explicit material, having children witness sexual acts, or being exposed to genitalia. Rape is defined as forceful, penetrative sexual contact. This can include oral sex, the genitals, anus. You may also be exposed to the terms of acquaintance rape, which is where the victim knows the perpetrator, or statutory rape, which means that the perpetrator was over the age of consent and the victim was not of the age of consent, could not give consent. The definition of sexual assault varies state to state. It's a subcategory of child abuse and not child neglect. This is the federal law's definition. It does not apply to the maximum age of 18 for other types of maltreatment, but rather indicates that the age limit in the state law shall apply. Sexual abuse is further defined to include the employment, use, persuasion, inducement, enticement, or coercion of any child to engage in or assist any other person to engage in any sexually explicit conduct or simulation of such conduct for the purpose of producing a visual depiction of such conduct, or the rape, molestation, prostitution, or other form of sexual exploitation. As I said, each state has its own individual laws regarding sexual assault or the abuse of a child, but this is a federal mandate. And as a competent nurse, one should be familiar with their state laws as well as institutional policy. Clinical manifestations include a broad array of signs and symptoms, both physical and psychological, but depending on the patient's sexual history, practices, and the nature of the assault, there may be little to no physical manifestation, but you always take what the patient states as truth. It should also be noted that children tend to externalize versus internalize, which means that they tend to project what's going on inside them versus keep it locked up. And the nurse should have already done by this point a self-assessment and think about how they feel about this topic, how they are prepared to deal with the topic, how they feel about the perpetrator, how they feel about the victim, and how they can handle reflecting on the situation, as transference and counter-transference can be an issue in this type of thing. And also think about how you might handle a very guarded child or defensive child. The physical manifestations can include ecchymosis, which is bruising, vaginal or rectal bleeding, genital or rectal pain, tearing, lacerations, pregnancy, vaginal or rectal itch, discharge, frequent or reoccurring UTIs, and STIs. And many of the first physical manifestations are only visible for the first 72 hours after the event. And psychological manifestations may be described as appearing suddenly or uncharacteristic of the child. And often the psychological manifestations are related to ineffective coping mechanisms and may resolve after medical therapy, interventions, and psychological treatment. Some of these include bowel disorders, such as stomach pain without an organic cause, eating disorders such as binge eating or anorexia, headaches that are often reoccurring, They may begin displaying disruptive behaviors and acting out, and this is usually noticed by the primary caretaker, or the school system will call attention to this first. They may begin abusing alcohol, street drugs, or engaging in high-risk activities such as sexual activities or drinking and driving, that sort of thing. They may have problems concentrating. You may see a sudden bout of excessive phobias or fears. And they often have sexual themes or are inappropriate for their developmental age. And you may see social or emotional withdrawal or isolation, and it may be one of the suddenly appearing symptoms. And the child may have preoccupation with their own genitals or concepts of sexuality.
All right, coping mechanisms. First off, you got to think that each person is going to have their own set of coping mechanisms. There is no set rule book to how a person's going to react to a situation like this. Here we have listed maladaptive, adaptive, and some neutral coping mechanisms. The ones by the stars in the adaptive column, those can often become maladaptive if they linger too long, if the person holds on to them too much. What I want to draw special attention to is the drug and alcohol abuse. A lot of times, especially in teens, they can turn to that as a form of masking that pain and covering it up. Well, of course, that can lead to more things, more dangerous stuff. Isolation. A lot of times, they won't want to be around other people. Their trust is broken in humanity. They don't want to put themselves in that situation again. Anger and distrust. Inappropriate use and control of others. They have a feel they want to control their situation. They want to control their environment around them. And that can also list risk-taking behaviors. This can be maladaptive in the form of cutting, doing crazy things, speeding, drinking, driving, all kind of stuff that kind of just puts them out there. It's like they have no care about what's going on at that form. Adaptive, I'm going to go over the ones that can become maladaptive. The forgetting and memory gaps, that is adaptive at first. It's like soothing the mind to not relive it. They don't need to relive that right after that happens. It's a coping mechanism that kind of soothes it for them. But as this goes on, they need to face that situation in order to move on and move past it. Another one is regression to an earlier developmental stage. This needs to they need to probably get past this, because regression past a certain point is also avoiding the problem. It goes back to that protective denial. At some point, they do need to move on past this and confront. Neutral sleeping pattern changes. I listed this as neutral because it's not necessarily bad, it's not necessarily good. It can kind of go either way depending on how they take it. You can see sleeping with the lights on, with stuffed animals, or fully clothed. I'm not talking about pajamas. I'm talking about like jeans, shirt, jackets, everything to kind of keep themselves concealed.
The first 72 hours after an assault has happened is extremely critical. During this time, if you have a pediatric present to the emergency room, maybe the physician's office, you're often going to see pelvic exams done, or physical exams of secondary characteristics such as like bruising of the arms. Anything that you see, you are going to note, and this is usually done by a SANE nurse, which is a sexual assault nurse examiner. They're certified, they've had special training. There's also a handout that Brittany's going to elaborate upon. But they're collecting evidence, and during this time, a lot of times they're going to be testing for STDs and pregnancy at this point, but they're going to be administering prophylactic drugs to combat STIs and pregnancy, but that's going to depend on the person, their religious views, such as the morning after pill or such, and the person should be given full explanation of what this is, and the nurse's own beliefs shouldn't carry into it. They should tell it like it is.
Okay. As our job as nurses and even other personnel that are involved in this kind of situation, it's our obligation to report this. I think we all know this by now. We've been over this. It's never a promise to keep it secret or anything like that, no matter how red that person is. It's our obligation to report this for our patient safety. Most institutions, they have their own protocol on how to deal with this manner, how to report it, and go about that, so you need to be familiar with your institution's protocol. In most institutions, the care, the evidence collection, and the interventions involving a sexual assault involving a minor is carried out by what we have saying the sexual assault nursing examiner. There's a handout that you'll have on this. It should also be noted that a female, if the female is present, a female should be present if the examiner is male. And generally, even if the examiner is female, there should be a female witness in there. This also helps the patient feel more protected, not so alone with that person, because you got to remember what they just went through. Okay, so a lot of times having a witness. If the guardians are not suspected of having done this, and it's okay with the child, maybe have their mom or their close guardian, whoever it may be, in there with them as another safety measure and another thing to decrease their anxiety. You know, having someone they actually know in there, because you're just another stranger to them. You know, they just had this happen, you're just another stranger to them. Having someone in there that they know and they do still trust can help decrease their anxiety. When you decrease their anxiety, it decreases their risk for harm, self-inflicted, other-inflicted, all kinds of stuff. However, it should be noted that parental reactions may vary. A parent may experience guilt, shame, anxiety, grief, despair, agitation, and as the nurse, you may even witness a parent blaming the child or adolescent. This goes the opposite. The parent shouldn't be in the room because this patient needs no more stress added. Remember to provide support and care to the parents as well. Listen to what they tell you and respond in a therapeutic manner. This is a manner of family-centered care, and it may be necessary to refer the group, the family, or the individual to therapy or some kind of support group to help them get through this. You have anything else?
One of the nursing diagnoses that we chose specifically for the patient to keep in mind is anxiety related to situational crisis, stress, unconscious conflicts, or the fact that something has threatened their ego. You know, as evidenced by would be patient complaints, changes in vitals, changes in mental status, narrowing of perceptual field, confusion, disassociation, and such. There is a diagnosis for rape trauma syndrome, but one of the things that NANDA is trying to do is get rid of this or kind of make it a last resort kind of thing, because it doesn't tailor to the patient necessarily. That's the argument that's being pulled right now, that they feel like anxiety or tissue trauma or something to that effect should take priority rather than using rape trauma syndrome.
We have other diagnoses that are listed there. There are many diagnoses that can be put in on this kind of situation depending on the patient and their specific situation. Each patient is different. Their reactions are different. You tailor it to your patient. It's not just the situation you're looking at. You're looking at your patient. You're looking at how she's reacting, or he or she is reacting. You tailor it to your patient and what's going on in that situation. I got a question. What would be the diagnosis on a chart in a trauma unit when this person comes in? Not a NANDA diagnosis, but when they come in, what would be their diagnosis in a trauma unit? It would be patient states they were da-da-da, or parent believes blah-blah-blah. That would be their admitting why they came in, that's why they came into the trauma unit. So that's what you would see on the admitting chart in the trauma unit. Okay? All right, some interventions. Like I said, the diagnosis is really, there's a lot of them for this kind of situation, so I just listed some of them. Of course, for our priority, we have the anxiety one. You want to promote privacy and a safe environment for this patient. You want to establish a therapeutic relationship through empathy and positive regard. You have to look at your patient again. Your patient wants to be close to someone. You can feel that? Yeah, but if they want you far away, don't push your presence on that person. Sometimes therapeutic touch is good, but in this situation, you never know. You may not want to use therapeutic touch because it may not be so therapeutic to this person. Some other ones, do not push. Don't push for them to talk about it. Maybe they're not in the state of mind to talk about it right now. Just be there for them. Silence, listening, those are all important in this kind of situation. Don't use stuff like everything will be all right because you're not in their shoes. Maybe they're thinking something else. Manage traffic flow because they don't need a whole bunch of people coming in and out and after they're just what they've just been through. Environmental factors like unnecessary lab work, stuff like that. Stuff that needs to be done right there, yeah, get it done, but unnecessary stuff that can be held off just a little bit. Maybe wait till he or she gets over that initial shock factor and can handle that kind of stuff. You do want to take your vital signs as tolerated. to identify the physical responses and stuff that's going on with them. And for ineffective coping, because they could have that, they have a lot of those maladaptive symptoms, or maladaptive coping mechanisms, identify their developmental level of functioning, assess current functional capacity. Now I want y'all to throw out some other interventions y'all would use for this type of situation. I got a lot listed here, so y'all can't be wrong. Don't be shy. I will call on somebody. Amanda.
Oh my goodness.
Come on. It's not that hard.
It's my Ativan.
So some calming mechanisms, like something for some anti-anxiety, stuff like that. What else? You don't have anything else?
Say giving a blanket a lot of times after the physical evidence on clothing.
Something to cover themselves, maybe? Yeah. Yeah. Promote, like, tell them different kind of coping mechanisms to use. Maybe they're totally at a loss from coping mechanisms. They don't know what to do. So give them some to try out, test out, you know. Anything else? Anything good? And that's where we can just... Good. That's it.